So I want to thank KDIGO for this invitation to share the Hong Kong experience about multidisciplinary care for patients with diabetic kidney disease. So this is the content of my presentation for the next 20 minutes. So you have seen a similar slide from Professor Philip Lee earlier on. His is more updated, mine is less so because I could only find this from PubMed. But this shows the number of people newly initiated kidney replacement therapy, and we see that the number has been increasing steadily in the last 30 years, approximately doubled in the numbers. And likewise, the proportion of kidney replacement therapy that is attributable to diabetes has also doubled. So now diabetes accounts for roughly half of the new cases of kidney replacement therapy in Hong Kong, and a similar pattern is observed in other areas as well. So of course that is hardly surprising because the pool of patients with diabetes has also increased. So in 2023, around 0.7 million people are living with diabetes in Hong Kong. That is out of 7.3 million of the entire Hong Kong population, just roughly 10%. But I want to say that the rise in prevalence is not so much the consequence of an increase in the incidence of diabetes. In fact, the incidence rate, or the number of cases, or new cases of diabetes per year, has been fairly stable in Hong Kong and also in other areas. And so the rise in prevalence is more to do with decrease in mortality. So in the last 10 to 20 years, in Hong Kong, there was a dramatic decline in the rates of cardiovascular complications by about 60 to 80%. And resulting from that is a parallel decrease in mortality, both mortality due to cardiovascular diseases and also mortality from all causes for the whole group, and especially for the older age group. And so the improved survival of people with diabetes, which is good on one hand, but it's also contribute to the increased number of people, of the pool of people with diabetes, and therefore leading to an increase in the burden of diabetic kidney disease at a population level. So we had the opportunity to analyze the database of Hong Kong Hospital Authority, which is the main healthcare provider of over 90% of residents in Hong Kong. So we examined the trend of incidence rate of kidney failure, which we defined as GFR less than 15, need of kidney replacement therapy, hospitalization with kidney failure, and/or death due to kidney failure. Following the initial decline, a modest decline in the rates in the first 5 years, has pretty much been stable thereafter, and that initial decline corresponded to the uptake or introduction of RAS inhibitor around that time. And so this is worrying, isn't it, when we contrast that against that large improvement that we see for cardiovascular disease. So I have to say that the medical management or care for patients have improved at an individual level. So why has the rate of kidney failure not improved? And I think a lot of that has to do with the change in the clinical profile of the population with diabetes, in particular an aging population who are more likely to have long disease duration. So that reduction in competing risk of death has really contributed to the lack of improvements in the overall incidence of kidney failure. And we see that when we look at the mean age of the diabetes population in 2002, it was 65 years, and in 2016 it was 67 years. And similarly, the age at which patients develop kidney failure has also gone up from 70 years old in 2002 to 74 years old in 2016. The prognosis of kidney failure is very poor. So about a quarter of them would die at 1 year, and about 3/4 would die in 5 years. When we look at the trend in 1 year and 5 year mortality, we did observe a slight decline for most age group, But if we look at the youngest age group, which is the green line, there was actually a signal of an increase in mortality after 1 and after 5 years. So this is another observation which I think is particularly worrying and really highlights the need to delay or avert diabetic kidney disease, especially in the youngest age group. Kidney disease was the leading cause of death in people with kidney failure, whereas cardiovascular disease was the leading cause of death in those who had kidney replacement therapy. We estimated that on average, the life expectancy was 3.5 years after diagnosis of kidney failure in the Hong Kong population. But this is the average. And so the number of years of life loss after kidney failure depends also at the age at which the patient presents with kidney failure. So that those who develop kidney failure at around the age of 45 years would expect to lose about 30 years of life, and that's a very long span of life to lose. And those who develop kidney failure at the age of 75 years would expect to have around 9 years of life loss. And here I want to share a recent study in which we looked at, we determined the population attributable fractions of risk factors for all-cause mortality in people with type 2 diabetes in Hong Kong. And out of all the risk factors which we examined, CKD was the leading risk factor, contributing to around 16% of all-cause death in our population. We also see on the right there that the distribution of risk factor or contribution of risk factor also vary by age group. So in the oldest age group, CKD is still the most important risk factor for all-cause mortality. Whereas in the youngest age group, so age 18 to 54 years, the strongest risk factor was actually suboptimal blood pressure. And I think that really ties in with the earlier presentation by Professor Ueki from his presentation of the J-DUET-3, where he highlighted hypertension is one of the important, if not more important, determinant for progression to kidney disease. And maybe in the youngest age group, we need to pay more attention about intensifying blood pressure control so that we can prevent CKD when they get to an older age, which then becomes the most important cause of death in that age group. And so amongst people with diabetes, the incidence of kidney failure has been fairly static in the last 15 years. And amongst those with kidney failure, mortality show only very little improvement. And this is partly due to improved survival, resulting in a changing profile of the diabetes population, which is characterized by a higher proportion of older individuals with long diabetes duration and likely to have multiple morbidities. So I want to share a little about the care of patients with CKD in Hong Kong and in Asia. This is an earlier study using JADE Asia register consisting of around 28,000 people with type 2 diabetes in Asia. So the frequency of albuminuria ranged from 29% in China to 63% in the Philippines, and the frequency of chronic kidney disease, which was defined by low GFR below 60, ranged from about 3% in China to 40% in India. And in Hong Kong, about 10% of our patients with diabetes had CKD, and about 40% had albuminuria. Those with CKD were less likely to be at glucose and at blood pressure targets than their counterparts without CKD. So we see that about a third of patients with CKD, only about a third of them were at A1C targets of below 7%. We're not even talking about the 6.2% in the J-DUET study. Only 20% of those with CKD reached a blood pressure target, which we set at 130 on 80 millimeter per mercury. Also, there was underutilization of RAS inhibitors, of antihypertensive drugs, and statins in those with CKD. So about half of the patients in this particular cohort with confirmed albuminuria were prescribed a RAS inhibitor, and about 60% of patients with confirmed hypertension or confirmed dyslipidemia were treated appropriately. So overall, people with diabetic kidney disease were suboptimally treated, and a lower proportion of them were at treatment targets compared to those with diabetes but without kidney complications. So lastly, I will talk about the local experience of multidisciplinary care of diabetic kidney disease. Recognizing the high burden and poor prognosis of DKD, in 2000, here in this hospital, we set up the Diabetic Nephropathy Clinic, which is essentially a subclinic of our usual diabetes services. So the project team includes the usual people, endocrinologists or endocrinology trainee, diabetes nurse educators, and pharmacists. So the reason why we do this is to have a smaller caseload so that we can spend more time with the patient and that they can be followed up a lot more frequently compared to the diabetes clinic. So all these patients will also be seen by our nurse and also the pharmacist at the same clinic visit as they see the doctor. So here we wanted to evaluate the effectiveness of this approach. So from the Diabetic Nephropathy Clinic, we identified 80 patients with DKD, and we put them in structured care. So within the structured care, as much as possible, we escalated their treatment to ensure that they reach multiple treatment targets. All the patients were assessed by pharmacists who then reinforced the patients on the medication adherence. They were seen every 12 to 16 weeks and had laboratory tests done before they were seen. And this group of patients were compared against 80 patients also with DKD but attending other medical clinics in the same hospital for the primary endpoint, which was composite of end-stage kidney disease and or all-cause mortality at 2 years. So this table shows the key performance indices. Almost 100% of those who were in the structured care had blood pressure measured at least 4 times per year, and A1C measured twice a year, and lipid measured at least once a year. And about 70 to 90% of them in the structured care were also intensively treated. And you see a significantly lower proportion in those in the usual care arm. So towards study end, the attained blood pressure, systolic blood pressure, and also LDL cholesterol were both much lower in the structured care group. So after 2 years of intervention, those who were assigned structured, or not assigned, those who were in structured care had a lower incidence of the composite endpoint as compared to those in the usual care clinic with a hazard ratio of about 0.4. Structured care also led to fewer events of end-stage kidney disease by 55% and fewer deaths by about 78%. And we also saw that the rise in serum creatinine was slower in the structured care from the baseline of about 200 micromole per liter to 280 in the structured care group, whereas in the usual care group, the increase was from 200 to 370. But of course, it wasn't a randomized controlled trial. And so the baseline characteristics of the two groups did differ. And we couldn't really control for that statistically completely. And therefore, that could itself lead to biases in some of the results. And so later on, led by Professor Juliana Chan, she conducted a randomized controlled trial including 200 patients with diabetic kidney disease, very similar in terms of baseline characteristics from this hospital. And this group was then properly randomized into structured care and then into usual care. And the protocol for structured care is very similar to the previous study that I showed earlier. So after 2 years, 24% of patients in the usual care and 23% of them in the structured care reached primary endpoint. So there was really no difference in terms of the primary endpoints. And also similar number developed a cardiovascular event. But what was different was the proportion of patients who reached targets. So that in the structured care group, about 60% attained at least 3 treatment targets versus only 28% in the usual care group. Thank you. And on the right-hand side is the Kaplan-Meier of the cumulative incidence of primary endpoints according to attainment of treatment target. And we see that those who attained at least 3 treatment targets in the dotted line had lower cumulative incidence of these endpoints as compared to those who failed to achieve treatment targets. And this is the largest and the most recent endeavor to test the feasibility and also the effectiveness of a structured care program implemented in many regions in Asia. So there were about 2,400 patients included. They were randomized to team-based empowered care, and usual care in equal numbers. Now, the primary endpoint for this study is the proportion of patients who attained at least 3 out of 5 treatment targets. So this is usual care, which is not exactly usual care because they all had a comprehensive assessment using the JADE portal. So the results of the assessment were then generated into a report, which was then delivered to the patient, explained to the patient of their control and so on. And a similar report is also sent to their doctor with automated decision support, focusing on care gaps and use of organ protective drugs. With the empowered care arm, patients additionally receive a telephone call from the nurses every 3 months to reinforce self-management and drug adherence and so on. And finally, those who were in the team-based empowered care, they were also seen by one of us, by endocrinologists or a trainee every 3 months, as well as a face-to-face nurse review and reinforcement. So here is the baseline characteristics of the cohort. It's really very similar to the usual patients with diabetic kidney disease, in that the mean age is about 68 years, diabetes duration is 16 years. About a third of them had cardiovascular disease at baseline. But you would note that quite a large proportion were already on RAS inhibitors and on statin in this particular study. And here are the results in terms of the primary endpoint, which is the proportion attaining at least 3 treatment targets. And it's only in the team-based empowered care where we observed an increment in the proportion of patients who reached the 3 targets. There was really no difference in the 2 groups. The study, one of the study's secondary endpoints is progression to major clinical events. So by group randomization or group assignment, the 3 groups did not differ in terms of progression to any events which include cardiovascular disease, heart failure, kidney disease, cancer, and death. And there was also no difference in the 3 groups in terms of the numbers for all-cause death. But again, when we stratified the clinical events by the attainment of treatment targets, again we see that those who attained multiple targets had fewer of these non-fatal events as compared to those who attained fewer treatment targets. And so this slide summarizes our experience with multidisciplinary care of DKD patients of the 3 studies. So all 3 studies recruited fairly similar patients, although in the J study, the kidney function was a bit better. But what is notable is the level of care has improved, spanning this 20-year period from 2000 at the beginning of the first study to end of 2018, which is the end of the J study, as reflected by the lower event rates in the usual care group across the 3 studies. And I think that itself could probably contribute to the lack of difference between the structured and usual care arm in terms of event rates. So some insights to share. So consistently in all of these projects, structured care improved treatment targets attainment compared with usual care. That was very clear. In all of these studies, patients who attained multiple targets were less likely to develop clinical events, which extend findings from earlier studies such as the Steno study or the J-DUET study. So that highlights the importance of target attainment. In managing patients with complex need, team approach combining intensive encounter with a specialist or a trained doctor, a nurse, and other supporting staff appeared effective. And I do want to highlight clinical inertia. Just because we measure things doesn't mean that we will act on things. And just because we act on things doesn't mean that we act on it properly. So clinical inertia may delay escalation of treatment. And I think when we are dealing with patients, especially those with more advanced CKD, I think inclusion of a specialist in the multidisciplinary team is critical, and it ensures success in terms of attainment of multiple treatment targets. And lastly, non-medical personnel or even IT can help to promote adherence to protocol by providing regular reminder, audits, and feedback. So integrated approach, including early diagnosis or screening, use of protocols with predefined schedules, prompt intervention, audits, and patient empowerment are needed to achieve the desired outcome. And with that, I will close my presentation. Thank you very much.